Please join me in welcoming Dr. Gaynor Watson-Creed to the stage.
So good evening, everyone, and I do recognize that I am probably standing between you and whatever happens after this event. So I will try and keep this brief. I have been asked to bring a different type of innovation to the stage tonight to close than the ones that you have heard before, the fabulous innovations that have come from my colleagues who have presented, and I do want to take this opportunity to say thank you to them for the inspiration tonight. The type of innovation that I'm going to talk to you about is something maybe that can be best characterized as this. I'm going to call it social innovation because I don't have another word for it. And yes, I do that currently on two fronts. One is in this position at the Faculty of Medicine as the Associate Dean for this portfolio called Serving and Engaging Society. Serving and Engaging Society is very much the aspiration of our current Dean, Dr. David Anderson, who's here tonight, to see the Faculty of Medicine extend itself beyond our traditional mandates of providing excellent medical education and excellence in research to serving communities in ways that might be unexpected from us as a Faculty of Medicine, from serving communities in ways that has us dig into those very deep, difficult outcomes that communities are searching for but that may be eluding them. And so there are two parts to the portfolio. One is called Partnering with Communities, and our equity, diversity, and inclusion work falls under that rubric. And then the other part is called Catalyzing Systems Change, and we see them as interrelated because, of course, if you engage with communities, they will tell you how the system needs to change, and if you're changing the system without engaging communities, you run the risk of changing the system in a way that doesn't actually serve anybody. So I'll talk a little bit about that work tonight. I also do have the privilege of serving as chair of the board for this organization, Engage Nova Scotia. And I believe Danny Graham, who is our CEO, and Tammy Ewing, who is our outreach officer, are here in the crowd tonight as well. The way I describe Engage Nova Scotia's work is that we are on a deep quest around the question, what if? What if Nova Scotia could become the vibrant, inclusive, equitable, and resilient place that the whole world aspires to be like? That quest and Engage Nova Scotia has us recognize that in order to get into that space, we actually have to look for the things that are barriers to us becoming vibrant, inclusive, equitable, and resilient. And so I'll talk a little bit about that work tonight as well. What these two things have in common is that they represent what I have come to understand and, quite frankly, love in my work as wicked problems. It's not my term. The term was actually coined for the first time in 1973 by two urban planners working on the wicked problem of city planning and municipal city building. The reason that I like wicked problems, I suppose, is that as a public health physician, I see them everywhere. And so if you think about wicked problems, what you understand is that these are those really sticky, thorny, tangly, messy, ugly. I know some of you want to leave right now because you're thinking about the wicked problems that you see. Those are the problems that we call wicked problems. In fact, even at my table tonight, we've had some conversations about what those wicked problems are. Taxes create wicked problems. Even our funding institutions and the way that we look for funding opportunities for research can create wicked problems. The healthcare system itself is a wicked problem, a complex system really creating as many new problems as it solves because it's so complex. That's the idea behind a wicked problem. And so if you're going to engage with wicked problems, you do need to know a little bit about how they're structured. So that original paper in 1973 actually spoke about 10 key characteristics of wicked problems. I'm only going to take you through 3 tonight. The first one is this one, knowledge uncertainty. What this represents is the idea that a wicked problem by its very nature evades our capacity to have all the knowledge that we need in order to solve it. I want you to think about that for just a minute. It evades our capacity to have all the knowledge that we need to solve it. Some of the problem is actually unknowable. Scary, right? And so this is why you hear people say things like, we're never going to solve world hunger. I don't believe that's true. But that's the idea behind a wicked problem. How could we possibly have all the knowledge that we need in order to generate the solutions for this, right? COVID-19 is a fantastic example of a wicked problem. If you think about where we were in March 2020, here in Nova Scotia, when that outbreak started, we did not have all the knowledge we needed about that virus and how it was going to evolve over time to make the decisions we needed to make, and yet we had to make decisions anyway, right? That's the type of uncertainty that you get into when you're dealing with a wicked problem. The second characteristic that I'm going to talk about is this one of value conflict. So this is the idea that as you try to define the problem, and remember, much of the problem will be unknowable, you attempt to define it anyway, and in doing that definition of the problem, you bring in your own values as ways of expressing what you think the problem is. The challenge is that just as you were doing that on one side of the problem, somebody else may also be engaging with the problem and defining it according to their own values. And so those values may come into competition with one another. And so which values trump? Using COVID-19 again as the example, which values are more important? Protecting people from getting ill or having society stay open? Protecting the vulnerable and the immunocompromised or going back to things as they were in 2019, right? And so that's the idea behind a wicked problem, is that you get those conflicts in values. The last point that I will bring you to in terms of defining wicked problems is this one. This actually happens to be my favorite one, dynamic complexity. So get this. What this means is that when you intervene in a wicked problem, the problem changes. So you intervene, and by nature of your intervention, you necessarily change the problem, which means it feels like you are trying to grasp onto water, right? As fast as you try and hold it, it changes shape, and then you have to figure out a new way to configure yourself to get under it and contain it. That's the idea behind a wicked problem. And so you end up doing this crazy bobbing and weaving, trying to keep up with the problem as it evolves, precisely because you try to apply a solution. Those are some of the challenges that you get into with wicked problems. And so to engage with wicked problems, I'm not going to lie, you need some skills, right, in order to do this. And so what are the skills that you would need in order to engage with wicked problems? Well, one of them is that you actually have to be comfortable with that bobbing and weaving. Another is this idea of starting somewhere, anywhere, with a wicked problem, and then following it everywhere it goes. Wicked problems create new problems. They actually create unintended outcomes. And so you have to be committed to looking for those unintended outcomes and then following them wherever they go and course correcting around them as needed. And so all of this points to being really comfortable with ambiguity, being really comfortable with emergence, as an example, and fundamentally committing to seeing the world the way it actually is, not the way we wish it to be, which can be a really difficult thing for people to engage with. So here are two examples of wicked problem work that I'm involved in every day. One is this one. And so we are a faculty of medicine at Dalhousie, so we have clinics for everything. We have a rheumatology clinic that we run with our healthcare partners. We have dermatology clinics. We have heart disease clinics. And yes, we have a white fragility clinic. And if you had asked me 3 years ago if I would ever be spending my days talking about white fragility with a faculty full of doctors, I probably would have laughed you out of the room. But we're doing it. And the reason we're doing it in no small part is because of this gentleman on the left, Dr. Ajay Parashram, who we work with regularly, and Dr. Eli Manning is also supporting us from the faculty of the School of Social Work. And I was at an event with Dr. Parashram where he finally, in a moment of frustration in this event on becoming an anti-racist organization, looked at the whole room and said, you know what I don't get? I don't get why we insist on talking about racism and we never talk about whiteness. And I'm telling you, that comment to me hit me right between the eyes. And I was in this place of, so we're doing that. We're going to do that in the Faculty of Medicine. And so we created a white fragility clinic. This is a safe space for faculty, largely white faculty and staff, to come and discuss the ways in which they are starting to understand how whiteness is central to upholding the conversation about racism, and it is having an impact. So what we're actually seeing is that faculty are more comfortable interrogating the role of whiteness in upholding racism, and they're going out and changing their environments, including the clinical environment, as a result of that. The second example I'll use is from Engage Nova Scotia, and here we are in a deep question about whether or not there is a measure other than GDP that gets more precisely at what matters in our communities and what our definitions of success should look like. And so in that conversation, we are now part of an international group of researchers looking at well-being economies, and that is taking us into some fantastic work on the basis of the quality of life survey that we did several years ago, and that we'll be repeating into the future. And so with that, we now have the largest database around quality of life in North America, and again, using that to start to define how we might look for measures other than GDP. So I will leave you with this. As we are engaged in this wicked problem work, we are identifying that there are leadership skills, in fact, that are needed to engage with it. The innovations that you heard tonight will all land in a space that is complex. They will land in a complex health environment space, they will land in complex funding spaces, and they will need the support of leaders who understand that complexity and are willing to engage with it rather than run the other way. And so for those of you who already do that, and I know many of you already have those skills, I give you my thanks. And my ask would be that certainly, for example, in the Faculty of Medicine, as we now embark on a new mission, which is around creating health system leaders that can equally engage with complexity, that you offer your support. And so happy to chat with any of you at any time, and I thank you for your attention.